What does stereotype or stereotyping mean? So the textbook definition of a stereotype is a preconceived notion, especially about a group of people. So it's having a fixed and generalized image of a group of people. And many stereotypes are either racist or ethnic. So example being Canadians are so nice, or French people only wear barrettes. They can be sexual, where people say that boys don't cry, or that women are really sensitive, or they could be homophobic, where people just say that gay men are really flamboyant. So it's just any set of idea people have about something or someone. So what is acute coronary syndrome? It's basically a umbrella term to describe many clinical manifestations that reduce blood flow to the heart. And the main condition that we know of is an acute myocardial infarction, but it also includes angina, unstable angina, atherosclerosis, non-ST elevation MI, and an ST elevation MI. So because of this reduction of blood flow to the heart, ACS is a medical emergency. And some common signs and symptoms include chest pain or chest discomfort, indigestion, nausea, vomiting, shortness of breath, diaphoresis, fatigue or weakness, there's restlessness, and a feeling of impending doom.
Myth or fact?
Drinking red wine is a good way to reduce your risk of heart disease. So this is actually a myth. So certain components in red wine may play an important role in protecting your heart, but it hasn't been proven to actually help. Alcohol actually tends to raise your levels of triglycerides, so that can actually increase your risk of heart disease. So some common causes of ACS include atherosclerosis, blood clots, and artery spasms. And some common risk factors include having high blood pressure, so the heart has to work harder than normal to pump blood through the blood vessels. Having high cholesterol and triglycerides, so having a high level of LDL cholesterol or bad cholesterol forms plaque and fatty deposits on your artery walls and blocks blood flow to the heart and brain. Other diabetes increases the risk of high blood pressure, atherosclerosis, and coronary artery disease and stroke. Also being overweight and having a sedentary lifestyle, drinking alcohol and smoking, and also stress.
Moving on to our next category, I will be discussing ethnicity and certain backgrounds which hold higher risks of having ACS. So as we all know, Canada is known to be one of the most ethnically diverse nations in the world. The GTA actually has a population of nearly 6.5 million, and more than half of which is a visible minority. So our main focus for this section will be on genetic dispositions carried by certain ethnicities, as well as accompanying lifestyles which, in some way or another, can affect the probability of developing an acute coronary syndrome. Our first group will be South Asian Canadians. So these are Canadians who are either born in or can lend their ancestry to South Asia. And this includes nations such as India, Pakistan, Bangladesh, Sri Lanka, Maldives, and Nepal. So while occurrences of cardiovascular diseases are globally declining, it has actually seen an increase in the South Asian population. And this can be traced back to high rates of diabetes, especially type 2, hypertension, and obesity. And these are all factors which share origins from traditional diets which are high in carbohydrates and saturated fats. And a typical diet would consist of lentils, vegetables, rice, meat, and various types of breads. And so with such a prevalence of comorbidities, the risk of acquiring acute coronary syndrome dramatically rises. Other factors reliably linked to South Asians include dysfunctional HDLs and elevated lipoprotein levels. And besides diet, another lifestyle risk factor for South Asians is lack of physical activity. So according to several studies, South Asians have comparably low physical activity rates. First Nations people are going to be our second group up for discussion, and they are also a high-risk population for ACS. So death from acute myocardial infarctions is 25% higher among First Nations men and 55% higher among First Nations women. when we compare that to non-Aboriginal Canadians. In addition to that, the median age of AMI patients from high percentage First Nation areas was 64 compared to 71 coming from low percentage Aboriginal areas. So already we're dealing with higher death rates and lower onset rates. Causes for this include lower socioeconomic status, high stress living conditions, incomplete diet, hypertension, and obesity. Like South Asians, the First Nations population also has a disproportionately high occurrence of diabetes, which comes up to be the biggest comorbidity in this group. And so unique to the Aboriginals is the common and sometimes cultural use of tobacco, with rates double that of the general population. Other high-risk ethnicities include Hispanics and Afro-Canadians, and the outlier in this case would be the Chinese population. They are at a statistically lower rate for developing heart disease and subsequently acute coronary syndrome.
True or false?
Over the age of 80, chest pain is rare and unusual. This is in fact true. As we age, due to physiological changes, decreases in pain receptors, different degeneration of nerves, pain sensation does decrease. ACS in people younger than 40 is associated with certain risk factors, much of which we've already discussed here today. Things such as diabetes, obesity, a positive family cardiac history, a sedentary lifestyle, other factors such as smoking and drug use, in particularly cocaine. We may be quick to rule out chest pain of an ischemic nature in somebody who's young, a younger patient, due to the stereotype that, oh, he's young, he must be healthy. They're breathing fast, they're a little bit sweaty, it must be anxiety. Or he's at the gym, maybe it's musculoskeletal. A good clinician maintains a very high index of suspicion in any case where, a patient is complaining of chest pain. Cocaine-induced infarction is particularly common in younger patients between the ages of 18 and 45. It is associated with vasospasm of the coronary arteries, similar to Prinzmetal angina, which also occurs in younger patients, followed by an activation of platelets. Increased platelet adhesion and aggregation furthermore contribute to the development of coronary thrombi, and thus ischemia of the myocardium. There may or may not be evidence of angiographic changes to the coronary arteries at this time. Elderly populations or geriatric populations or old folks are at increased risk of mortality and morbidity due to age-related physiological changes and polymorbidities such as vascular disease, hypertension, chronic heart failure, various arrhythmias, and renal impairments. There's usually multiple chronic problems that are all active and interacting with one another all of the time. Polypharmacy is another factor which plays a role in cardiac events of the elderly. There are increased risks of adverse drug reactions, the increased cost of medications, and as such, non-compliance can become an issue. Older populations, geriatric populations, receive a pension many times and live in lower income areas, which according to a recent nationwide study, stacks the odds against survival of a cardiac event. On average, EMS providers arrive 4 minutes later in low-income areas compared to higher income areas. Compounding this issue, a lot of elder patients or elder people live in apartment buildings to maintain their independence, and that can have longer access times associated with it as well. Although the cause is unknown as to why this disparity exists, we can avoid stereotyping low-income areas as unsafe and respond just as timely as we would in a safe area or in a nice area. Don't stage and wait for police or fire unless there's a legitimate risk for your safety.
Myth or fact? Women who have suffered heart attacks tend to wait longer than men before seeking medical help. This is a fact. Women are less likely to seek medical attention due to their atypical signs and symptoms. They usually don't know they are having any sort of cardiac event, therefore they don't seek any medical help until much later. Let's move on to our next category, which is gender. Gender differences play a very big role when it comes to dealing with a patient with acute coronary syndrome. Men are at risk for developing ACS starting around the age of 45. Studies have shown that men are 2 times more likely than women to have their first acute MI. This can be attributed to many different risk factors such as stress, smoking, excessive alcohol intake, obesity, diabetes, and much more. If you take a look at the figure on the right, you can see that men have a significantly higher prevalence of developing ischemic heart disease, heart failure, and acute MI than women, and this value just keeps increasing over time. Most male patients present with typical chest pain as well as signs and symptoms like tightness and pressure in the chest, shortness of breath, feeling dizzy or lightheaded, nausea, and sweating. These signs and symptoms often trigger diagnostic testing for ACS early in time. This allows male patients to get diagnosed and treated earlier for their symptoms, which ultimately leads to less comorbidities. Women, on the other hand, are at risk for developing ACS starting at about the age of 55. They are also more likely to present with atypical signs such as weakness, diaphoresis, shortness of breath, cold sweats, and pain in the arms or shoulders. Not presenting with the classic symptom of chest pain results in more women being misdiagnosed or underdiagnosed in the emergency department and essentially having a higher mortality or comorbidity rate compared to patients that presented with chest pain. Due to these atypical signs, women are known to seek medical attention much later than men. While men and women share a lot of common risk factors, some of these risk factors weigh more heavily in contributing to ACS in women than in men. Women who have diabetes, hypertension, and who smoke premenopausal all have a higher prevalence in developing acute coronary syndrome. Studies have also shown that the loss of estrogen in women after menopause has widely been attributed to an increased risk of ACS. So, now let's talk about how stereotyping comes into play here. There have been many studies that show women, in particular, tend to receive pre-hospital care not fully to standard due to some healthcare professionals that hesitate to expose the female chest. Transgender people are more likely to abuse substances and alcohol and are more likely to smoke, which puts them at a higher risk for developing acute coronary syndrome. When we talk about transgender patients in the pre-hospital care, are we stereotyping? Well, the number one thing that we must do is keep our judgments and curiosity to ourselves and focus on providing care. We must also take into consideration how we would address the patient. We should try to avoid terms such as ma'am and sir until we properly and politely ask how they would like to be addressed. Lastly, if you do feel too uncomfortable, always remember that you can take a step back, gather your thoughts, and ask your partner to run the call.
So, am I stereotyping? While we shouldn't stereotype patients we encounter, we should incorporate information and statistics to help us paint a complete clinical picture. Reliable data available to us includes information on age, gender, and ethnicity, and how these factors affect the likelihood of developing an acute coronary syndrome. Thank you for listening.